Perfect. So we can start now. So hello everyone, welcome back. Uh, to all who made it today. I know it's a lot of traffic, and so this is part three, Dementia Basics Part Three. So if you have any question about the handout, let me know. But also, just to let you know that we're gonna use handout number one as last week for this last session about. It's called also the science of dementia. And that's from pages 19 to 22. All right, so you're going to follow that. In addition to that, there might be some slides that I have to send to all of you. Just a reminder that next week we have no session. Okay, so we have a week off. Then we continue on December the 11th, okay, with part four. And it's going to be about understanding behaviors in dementia. All right, so we are extremely lucky to have our speaker today with us. And it's Dr. Neil Thomas. He's a neurologist at Bruyere Memory Program. Dr. Thomas completed his medical school and neurology residency at the University of Ottawa. Then he completed his fellowship in geriatric neurology and dementia at the Oregon Health and Science University and Portland Veterans Affairs Medical Center in the USA. And also his research focus is on using home-based technologies to evaluate people living with MCI, mild cognitive impairment, and helping caregivers also activities. So without further ado, I also will ask you for a round of applause for Dr. Neil Thomas, who is a great collaborator as well, and a researcher. Welcome, Dr. Thomas.
Great, thank you.
So this is your microphone.
Okay, I can clip that on. I'll clip it on and hopefully let me know if I
I
can.
always miss a good picture here.
All right.
Thank God.
Okay, so hopefully this microphone is in a good spot for everybody who's listening online. And yeah, I'm very happy to be here and being able to present these in person again. So I'll be doing part three of the science of dementia, and we'll start with just a little recap of the first two sessions, and then we'll go into the topic for today. So for the first session that was done a couple weeks ago, I think it was Dr. Frank who went over parts of the aging brain and what the brain does in different anatomy. Part two was a bit more about chronic disease, what is dementia, different types of dementia. And then today we're going to focus a little bit on just how do we actually make a diagnosis of dementia, what do we do in the clinic, understanding the pathology, so what's causing different types of dementia, and some advances in diagnosis and treatment, and then information on research and in clinical trials. So just quick review for part one and two. So here we have an overview of the brain, looking at it from the side. You can see the different lobes of the brain that we sort of separated into based on different aspects of the brain function. And so when we look at what different parts of the brain does, it is sort of sectioned off and different areas perform different functions. So hearing is a bit more represented sort of deep inside the temporal lobe here. So that's where we start to understand what's being said to us. And vision is in the back part of the brain here in the occipital lobe. Actually, there's a lot, we're quite visual creatures, and so a lot of the vision system comes into the temporal lobe and the parietal lobe, but this is more sort of vision for understanding what we're seeing, and then this is vision for action and being able to kind of form a mental map of our world. Executive functioning, that's decision-making, sequencing, planning, more complex tasks that we can do as humans. That's also the last part of the brain that develops as we're growing older. So if there's teenagers that that are making not great decisions, that's because this part of the brain is still developing. So, but it helps with, as I said, judgment, decision-making, multi-step tasks, and complex things like that. Language is represented in larger parts of the brain. It's another big part of our understanding of the world and how we communicate with others. So the understanding of language is more in the temporal lobe, and then there's a little connection that runs all the way back through there to the frontal lobe. This should be a little bit farther forward for speech production. So there's sort of more understanding of speech here and production of speech in the frontal lobe. Visual spatial, as I mentioned, that's kind of like more the processing of visual information, our mental map, knowing where we're going. Right now, I'm looking around and I can see there's people in front of me, there's a door over there, and I need to represent that so I can navigate through my world. Orientation, so that's knowing the date and the time and things like that, and that's more in the temporal lobe. Now we're looking sort of at the brain right down the center. So we've kind of sliced it right down the middle here. And this is looking from the inside here. Same sort of lobes. So there's the frontal lobe up here, the parietal lobe, occipital, and temporal. Olfaction, so our sense of smell is pretty deep here and in the brain. And then memory, so obviously an important thing we'll be talking about today, and consolidating, taking something that we learn and actually bringing it into our long-term memory so we can remember it at a later date, happens a lot in this middle part of the brain, in the temporal lobe. So we have billions and billions of neurons in our brain, and that's why we can do some pretty amazing things. What happens for us to send signals in the brain and for our neurons to connect and talk to each other is we have electrical signals, and then we have a chemical signal sent between the two different cells. So this is a neuron. This is the main cells in our brain that send these signals. We have an electrical signal that is formed in this part right here. And then it goes all the way down, and these areas here, this myelin, that's kind of like the electrical wiring, right? So we want the signal to go through nice and fast. And this is sort of like the insulation of the wire. And then it goes to the end, and we have the end of the axon. What happens there is there's a release of a chemical messenger or chemical molecules that will then go through this, very, very micromillimeter space, like microscopic space, from one cell to the next. And that will either activate the next cell or inhibit it. And so that's important. There's this balance between activating things versus inhibiting, depending on what we want to do and what part of the brain we want to be active. And this is important when we'll talk a little bit about medications, because there's different brain chemicals in different parts of the brain. But many of them are released in the same way. They're released by one cell, and then they come and act on the other cell. And when they go into that molecule, that receptor here, they either activate the next cell or inhibit it from being active. So as we get older, we lose brain cells, and I'll talk about that in a second, but the way that we keep learning things is by establishing new connections. So each brain cell has thousands or then thousands of connections, and that's the way that we send signals, and we are able to do more complex things. Interestingly, we start with the most connections when we're quite young, and then some of the learning is actually taking away connections that are not important. So a baby can't process things as well because there's just too much information coming in, and it doesn't know how to interpret one thing versus another. So it starts to learn that, well, if I want to move my arm like that, I'm going to strengthen this pathway, or if I want to, as my visual system is becoming more advanced and adapting more to be able to see the world, changes are happening to strengthen those connections. And with the brain, because it's doing so many things, it is actually the part of the body that's most active in terms of the amount of energy it takes, proportional to its size. So it gets a very rich blood flow. It also takes a good chunk of the energy that we use to run our whole body. So you can see here, this is just a diagram, excuse me, of the different blood flow, so coming up from the arteries to the brain. And there is a bit of redundancy, so we want to have as much blood flow, and sometimes we have, areas being fed by two different arteries. Unfortunately, that's not perfect, and as we know, we can have a stroke where one of these blood vessels is blocked off. If it's a larger blood vessel, unfortunately, more of the brain can be affected, and then you lose the energy supply and oxygen going to that area, and that causes brain cells to die off. But again, the brain, very rich in the number of blood vessels it has, because it needs a lot of energy to do all the work that it's doing. So as I mentioned, we do lose brain cells all through our lives, although we have the most brain cells when we're a baby. As obviously, there's lots of things that they need to learn. So having too many brain cells and too many connections isn't necessarily a good thing. You need to have the right connections doing the right thing, and that's how we learn over time. But on the other side, unfortunately, the brain is one of the organs in the body where we don't have the ability to regenerate brain cells. So there's a couple small areas that do, but overall, once brain cells are lost, they're lost for good. So over time, we are losing brain cells through our life, and if over the whole span of our lifetime, we lose about 10% of our brain tissue and our brain cells. That seems like a lot, but thankfully, again, they're strengthening connections, so we're still able to learn things through our entire life, because that's the way that we sort of store information, is by strengthening those connections that are important for what the brain is doing, and that can change, all through your life, and so that's why it's important to remain, active mentally and physically, and by learning new things. There's no reason that needs to stop. But unfortunately, this does lead to some changes that happen over time. So certain aspects of memory and thinking do decline as we get older. We're not quite as able to, multitask. Might not be able to manage things with a bunch of distractions as well as before. There's a lot of times you might search for a word a little bit more as you get older, as well as having those moments where you walk into a room and wonder why you're there. Those are all kind of normal things that can happen as we get older. And that is in part due because there are changes happening to the brain, and we are losing some of that brain cells over time. And I'll talk, as we talk about how we diagnose it, what's a little bit more concerning, right? So we have normal aging, as I mentioned. There's mild changes, like I talked about. So, certain little changes to memory, language, and function. Our wealth of knowledge and our sort of wisdom can continue to accumulate over time, though. So when we look at normal aging, we have mild changes in what happens to memory, language, executive function. And actually, I'll just step back a second. I know it was taught in the last time, but when we look at what the brain does, there's different cognitive domains, so different aspects of memory and thinking. Memory is one of those. I talked about executive function being in the front part of the brain. Maybe what teenagers don't do too well, but it's the more complex judgment, decision making, things like that. Language, visual spatial function. So that's, can you put together IKEA furniture? Can you navigate to work? Can you draw complex objects? And then, personality and behavior. So those are the main sort of aspects of what the brain does, and we break those down into different cognitive functions. So those remain fairly stable as we get older. And then IADLs means instrumental activities of daily living. So that's the more complex things like managing your finances, working, driving, managing your schedule and your appointments. All of these things should stay stable as we get older. We shouldn't have any loss of function, even as we age, for memory and thinking changes. MCI means mild cognitive impairment. So that means problems with memory and thinking that don't significantly impact your day-to-day life, but are more than just the normal aging process. So in that, we do see more significant changes in memory or language or other aspects of cognition or thinking. But our instrumental activities of daily living and our day-to-day functioning should stay the same. Maybe you're a little bit slower. Maybe it took you a few days to put together your taxes instead of one afternoon, but you're still able to do things independently and on your own. And you're not needing help. But our memory tests, or people may notice, more significant changes in memory and thinking, not just that sort of occasional little memory lapse. And dementia means problems with memory and thinking that do significantly impact your day-to-day life. And so that's, again, we get more significant changes in memory tests and memory and thinking when we do tests in the office. But there's now impairment in instrumental activities of daily living, or eventually, and much later in the disease, basic activities of daily living. So those are more basic things like dressing, bathing, feeding yourself. So that's the big difference, is the change in function is the difference between mild cognitive impairment and dementia. And obviously the changes in memory and thinking do get worse as people progress through the stages of dementia. So why, do we have an entity like mild cognitive impairment? Why is it important to maybe understand things or identify things a bit earlier? Well, in some cases, unfortunately not as many as I'd like, but in some cases with mild cognitive impairment, we can identify things earlier and watch things a bit more closely, or sometimes, identify a medical issue or another problem that could be treated and allow people to sort of improve. So sometimes we might pick up problems on these memory tests that could be improved by treating something like severe depression, severe sleep apnea, things like that. Unfortunately, though, in general, and the most common thing is when people have mild cognitive impairment, they either may stay stable, or more commonly, they decline over time to dementia. So it's sort of a risk state for dementia, and it's important to sort of identify that to be able to follow things over time, and help people understand they might need help with things moving forward if there are changes that are progressively getting worse. So learning and unlearning, the concept of these day-to-day functional activities. When you start out as a baby, you have to learn very basic things, just how to hold your head up, how to look at objects, paying attention, then finally single words. It becomes more complex. You start to learn, one-step directions using a spoon, things to feed yourself. Through grade school, you learn your vocabulary, brushing your teeth, dressing, then reading and things like that. And eventually, so you can do the more complex things that we need to do and manage in our day-to-day life, such as managing our finances, holding down a job, driving, different things like that. The idea with dementia, though, is it's the more complex things that are lost first, and it's this idea of unlearning. So instead of going from a baby to when you're older, you went down in this progression. With dementia, you start to lose the more complex things first, and then the idea of unlearning is sort of going backwards, where the more basic things may be lost eventually, but not until much later in the disease. So when we talk about dementia, dementia is not a specific disease. Dementia is an umbrella term. It means problems with memory and thinking that significantly impact your day-to-day life. It can be caused by many different things. Alzheimer's is one of the more common causes of dementia, but it's not the only cause. So there's other types of neurodegenerative diseases, which you would have learned of in the last few weeks, like Lewy body dementia or Parkinson's disease, frontotemporal dementia. But dementia is just that general term. So when we make that diagnosis, we then want to look and say, well, what do we think the cause of that is? And so there's different diseases that we look at, and things are moving forward. We are getting some new methods of diagnosing things like Alzheimer's and different types of dementia. Right now, though, it's still primarily a clinical diagnosis. So we take the information we have, and based on the pattern of deficits that we see, more likely if someone's having progressive deficits in short-term memory, maybe orientation, not knowing the date and the time as well, maybe making some minor errors in their navigation. If it progresses and gets worse over time, more commonly that's due to Alzheimer's disease. Alzheimer's disease, we think the basic cause behind it is two proteins in the brain that become abnormal. So there's amyloid and tau. These are proteins that everybody has in their brain. They have very important functions. But in some people, they start to become abnormal. They fold in the wrong way. They start to clump together. They then become toxic to brain cells, and they kill off brain cells over time. So we see here on the left, the normal neuron, everything looks healthy. But in Alzheimer's disease, we have the tau protein forming these neurofibrillary tangles, and those are inside the cell. And again, they kill off cells over time. And the amyloid protein forms these amyloid plaques outside of the cells, but also they're damaging to brain cells over time. We're now understanding dementia is a very complex thing. It's not just these two proteins, but these still form the basis of what we consider Alzheimer's disease. There's probably lots of other things that contribute to developing these amyloid plaques and tangles, and other things that can make symptoms more prominent. So you can sometimes have a lot of these, especially the amyloid plaques. The tau is a bit more tightly linked to the stage of dementia. And so generally more tau and neurofibrillary tangles means that someone will present and have cognitive difficulties and problems in their day-to-day functioning. And the extent of tau tangles in the brain does correlate a little bit, or is associated a bit, with the stage of the disease. Amyloid doesn't associate as much. If it's there, it means you probably have Alzheimer's disease, but some people can have a lot of amyloid in the brain, and if there's nothing else, there's no blood vessel changes, there's no tau tangles, they may actually not have a lot of symptoms of memory and dementia. So there's where that complexity comes into this type of disease. But we do know that these are sort of linked together in Alzheimer's disease, and probably amyloid seems to come first and then worsens this buildup of tau tangles. Vascular disease, it can cause vascular dementia. So this is all related to blood vessels. There can be changes from either someone who has a stroke. After you have a stroke, there's a higher risk of having cognitive impairment and dementia. It's very important if someone's had a stroke to try to, identify the cause and treat that, because any subsequent stroke significantly increases their risk of dementia. So preventing that second stroke is really important as well. What happens with vascular disease is blood vessels get blocked off generally. There can be either a stroke due to a blood clot, or sometimes there's bleeding strokes where a blood vessel breaks open, blood spills out, and we lose again, the blood flow to that area. But much more commonly is a blood clot. If it happens in a larger blood vessel, it can cause more significant damage in that one area. The other thing that happens over time is, unfortunately, like other organs in our body, our blood vessels in our brain, they get older. There's hardening of the arteries. They're not as healthy at 90 as they were at 30. So we can sometimes see small blood vessels causing some scarring and hardening of the arteries. And so we can have not only dementia or vascular dementia after a stroke, but if someone has significant buildup of blood vessel or vascular disease, then sometimes that can cause dementia itself too. So that's why it's important to, obviously stay physically active, but treating things like high blood pressure, diabetes, high cholesterol, avoiding smoking, those are all very important things to keep your blood vessels healthy. And as I mentioned, when people have, some Alzheimer's changes, they may have milder symptoms of dementia, but when you add more things together, there's Alzheimer's changes, and now there's also unhealthy blood vessels. That's more likely that the person's going to have more significant problems with memory and thinking and more significant signs of dementia. And again, right now, we'll talk a bit later, there are some new treatments coming out for, or that are being researched for Alzheimer's disease, but things like vascular dementia, we do have, better ways to treat and prevent complications from this. So identifying those things early through your younger age and middle age, can help with the aging process and reducing the chance of having memory problems later. Lewy body disease is generally associated with Parkinson's disease. So we talked about amyloid and tau as the proteins in Alzheimer's disease. In Lewy body dementia, it's another protein called alpha-synuclein, and it's the same protein that's abnormal in Parkinson's disease. The difference is not really what's happening in the brain. It's the exact same kind of process. It's these buildup of Lewy bodies or alpha-synuclein in brain cells in Lewy body dementia. What happens to differentiate Lewy body dementia from Parkinson's disease is usually these Lewy bodies build up more in a deep part of the brain that's involved in initiating movement, whereas in Lewy body, they go there, but they often go in, it's spread throughout the brain earlier on. So people can have a Parkinson's disease-related dementia that may develop years after they develop Parkinson's, or they could have dementia as the first presenting symptom, and have some of these changes related to Parkinson's type changes and dementia happening at the same time. And that's usually more likely due to Lewy body dementia. The difference between this compared to Alzheimer's is people generally present more with problems with visual spatial function. They're very slow in their thinking process. They have Parkinsonism, which means slowness and stiffness of movement. Visual hallucinations more commonly happen in this disease, although they can still happen in Alzheimer's. It's not only Lewy body dementia, but often they happen early and they're quite prominent. REM, behavior sleep disorder. So when we have rapid eye movement sleep, that is often when we dream. We don't want to be moving around when we're dreaming, so our body sort of often paralyzes the rest the brain sends a signal to paralyze the rest of the body. So we might have dreams where we're running after things or being chased, but we're pretty quiet and not moving in the bed. In REM behavior sleep disorder, that signal is kind of lost and people start to move around, act out their dreams. So if someone says their partner is, flinging their arms out and hitting them or rolling out of bed, that can be a sign of that. And now we know for some reason that's more closely linked to Parkinson's disease and Lewy body dementia. Again, so if you have REM sleep disorder, it doesn't mean that you're going to get Parkinson's disease, but it is a pretty high risk and a stronger association. People have more visual spatial difficulties, so difficulties with navigation and things like that I talked about, and fluctuating attention levels often. And this fluctuating course is more meaning that, everybody has good days and bad days, but people with Lewy body dementia might seem fairly normal one day, and then the next day they're really drowsy, maybe a little bit confused, altered level of consciousness. So it's a big change, sort of hour by hour or day by day. Parkinson's plus disease. So interestingly, these are diseases that have symptoms of Parkinsonism, but are actually not due to that alpha-synuclein and Parkinson's protein. They're actually due to frontotemporal dementia. They're much less common, thankfully. They usually have more significant problems with executive function. So people are very slow in their thinking. They have difficulty with multitasking complex tasks. They often have signs of Parkinsonism or difficulties with walking and depression, or actually it's more often apathy. So these people have less initiative, less drive to push to do things in these types of diseases. But so they got called Parkinson's plus diseases or syndromes because they have Parkinsonism often associated with them, but they're actually, when we look at what's happening in the brain, the proteins that are becoming abnormal are more likely due to frontotemporal dementia. So that's the overview of the last couple weeks, and now I'll go into part 3 today. And again, during this, if anybody has any questions, please feel free to stop and ask me. So I'm happy to answer any questions. So how do we make a diagnosis of dementia? So when we see people in the clinic, people are generally referred from their family physicians, and it's because most often someone in their family has noticed changes. Sometimes people do early on see changes themselves, but this would be a fairly common example. So we may have someone who's in their 70s. This person is forgetting, why she went into the basement. Maybe that's not as worried, but worrisome to her. But her family's seeing, well, this seems to be more than just that. She's forgetting things that we tell her about, maybe forgetting things that happened a few weeks ago. It's getting worse over time. So it's not just these, occasional memory lapses. Oh, I went down to get the laundry soap, but I forgot about it. And it seems to be more memory slips and problems than her friends and her peers. She's starting to have some difficulty with paying bills. And as I mentioned, that shouldn't change over time as we get older, unless there's changes happening with memory and thinking. Maybe forgetting things she has at home, double buying things, and then, again, some changes in day-to-day functioning where her husband's having to help out with chores a little bit more than before. So how do we diagnose dementia? Other things that we need to know about. First off, as I mentioned, so in this case, we want to get history from the patient. Sometimes they may not be aware of what's happening, so the person experiencing the cognitive symptoms. So, in any of my visits or the clinic visits, I always want to have a family member or a friend there who knows the person well, because they might be the ones that are seeing more of these changes and give me more information about what's actually happening. So you want to get information from the person. We want to get information from a good informant, and then we get some background as well. So it's important to know about family history. Some of the diseases that I mentioned have a bit more risk if you have a family member. So Alzheimer's disease does have a bit of a heritable component, meaning if you have a family member with that, your risk is slightly higher. It's not a guarantee though, so it's not like if you have, yeah. Less commonly. So Parkinson's disease and Lewy body disease, there are genetic forms of it, and there are certain genes that increase your risk. But in general, Lewy body doesn't have as much of a genetic component that seems to transmit from or family members. So if you have a family member who has that, there's not as much of a risk, unless again there's these very rare, very small number of genes that can be causing Parkinson's disease or Lewy body dementia. But yeah, so if we looked at, what's the percentage risk of you having Alzheimer's disease if you have a first degree relative, it would be higher than if you have a first degree relative with Lewy body dementia. So again, but it is important to look at family history, and so that is something that gives a bit of an idea of again, if you had a family history with multiple people in multiple generations with Alzheimer's disease, that would mean probably there's a mix of genes that you might have that increase your risk. Whereas social history is important to know about in terms of the level of education, also some of their habits, in terms of alcohol intake, smoking, and different things like that. Medical history. So are there other medical conditions that we need to think about that could be causing dementia or contributing? So in this case, the person has osteoarthritis and they've had their hysterectomy, so had their uterus removed. these wouldn't be things that we generally associate with the risk for dementia, but certain other things are important to know. And especially if we're looking at vascular risk factors, people who they're smokers, they have high blood pressure, they have diabetes, all of these things are important to think about when we're trying to figure out what could be causing the dementia. So we want to get, again, pinned down what are the symptoms that the person's experiencing. Because as I mentioned, that can maybe help us give us a better idea of, is this more likely to be Alzheimer's disease versus Lewy body dementia versus vascular dementia? So in this individual, there was more problems with short-term memory, their orientation or sense of time, and maybe some minor word finding difficulties. So searching for words, but more than just that occasional time. After we've gotten information from the person experiencing the symptoms and their, again, family member or friend, we then want to also get some evidence of changes in memory and thinking using cognitive testing. So we use different tests. There's the MMSE, which stands for the Mini Mental Status Exam. More commonly now, we use something called the Montreal Cognitive Assessment, and these are tests that look at different aspects of those cognitive domains, so memory, language, attention, executive function, and visual spatial function. In the MMSE, scores above 25 are normal, so this person is scoring lower than expected. And again, this can also give us an idea of what the type of dementia might be based on the types of problems they have on the testing. So this individual had problems with memory and orientation more so than other aspects of the test. A physical exam, so we want to more look there for, again, other medical conditions that could be a factor or could show signs of a different type of dementia. I would look for signs of Parkinsonism, like slowness and stiffness. Here they mentioned no asymmetry. That is because signs of a stroke would usually present on one side of the body or the other. So if there's something that suggested that one side was a bit weaker, or there was signs on one side, then we might be looking at the the brain imaging or the MRI a bit more closely. Usually, though, in cases of individuals who have Alzheimer's disease, we don't really find anything on our neurological exam. Physically, they're often healthy and there's no signs of any problems. We also do a number of laboratory tests to make sure we're not missing any reversible or changes or other medical causes. So we check, liver function, kidney function, vitamin B12, is there a thyroid imbalance, and things like that. We also want to get brain imaging. The main reason for that, and it's quite rare to have an abnormality on the imaging that we're not expecting, but in a few cases you could have an undiagnosed brain tumor, or some people also have silent strokes, right? They never presented with facial droop or slurred speech or weakness on one side of the body. Maybe it was in parts of the brain that are more important for language or memory and thinking, and so it didn't present really easily to see. So that's important. We can get an idea of, how much vascular disease is there? Is there a silent stroke that happened? Or again, in very rare cases, making sure we're not missing something like a tumor that would be treated, and that could be potentially just taken out. Mild atrophy, that means shrinkage of the brain. So the other thing that these tests give us is a bit of an information to support our diagnosis. So as we talked about with things like Alzheimer's disease and some other types of dementia, these are neurodegenerative diseases. Brain cells are dying off over time, so we see more shrinkage of the brain than we would expect in the normal aging process. And we want to look at medications too. So certain medications can make you a bit foggy, slow down your memory and thinking. So, this is an example that's brought up here for a specific reason. So Tylenol is not a problem, but amitriptyline, that's an older style or older class of antidepressant medication. It works fairly well, but unfortunately it does have some side effects. Not everybody that takes it is going to have these problems, but some people feel slow. They have a bit of brain fog or slowed thinking on this medication because it blocks one of the brain chemicals that we think is important for memory. And I'll talk about that in a second, but we want to look at that and say, well, maybe, this could be contributing. Might not explain everything, but if it is something that's causing a little bit of drowsiness or brain fog or slowed thinking, maybe it's something we should remove and see how the person's affected by that. I have had people who are on quite a few medications that affect the brain, and changes to those have made a big difference. The other thing to look for is over-the-counter medications. So a lot of people don't think about that. There's a lot of prescribed medications that can cause slowed memory and thinking, but many of the over-the-counter things like Gravol, Benadryl, and then anything that has a PM on it that's meant to make you drowsy probably makes you a little foggy too. So it is important to be thinking about those medications, especially for people with dementia, but for anybody in general. As we get older, too, we want to look at what are we taking. So it's always good to maybe check with your pharmacist about some of these medications, especially things like Gravol and Benadryl. They can make people quite drowsy. And they end up in a lot of little things as the PM component to make you drowsy. So diagnosing, so right now, most diagnoses that we make for dementia are still a clinical diagnosis. So the only way to 100% confirm that someone has Alzheimer's disease or many of these neurodegenerative diseases is to take a piece of the brain and look for these abnormal proteins. We obviously don't do that during life, but we are developing new methods to diagnose this. So there's some that are done right now, really mostly in research settings. So there's new PET scans that are being developed. And we have little tracers that can actually tag on to the abnormal forms. Like I said, not just amyloid, because everybody's got amyloid in their brain, but they can tag on to the abnormal amyloid in the brain. And then this PET scan is like a special type of a CT that looks for the abnormal tracer that has been taken up in the body in areas that have abnormal amyloid or abnormal tau. Still, these are being done in the research setting and sort of being looked at for clinical use because we want to make sure if we do tests that they're accurate, that they're telling us the right thing. We don't want to tell someone, oh, you've got a lot of amyloid and tau in the brain, and that's a false positive. There's also more excitingly blood tests that are being developed, and those are getting very close to being used. I think being able to be used in the clinical setting. And hopefully they could be used in the place of more expensive scans like a PET scan. The other way that we can be a bit more definitive in our diagnosis of Alzheimer's disease is a lumbar puncture, but that is something that is a bit more invasive. Most people don't want to go through. So being able to do a blood test would be much better than that. The PET scans are also very accurate, but they're very, very expensive. And that's part of the problem of trying to use these in a wider scale for our healthcare system. So in this case that we're showing here for this individual, bringing all of this information together. So we see someone who has progressive changes, mostly affecting memory. They scored lower than expected on their memory test, and they had a bit of shrinkage of the brain on their scan. This would fit best with mild stage dementia due to probable Alzheimer's disease. So with treatment, as I mentioned, we don't have a cure. We don't have diseases that stop this right now. But the treatments we have, one of the medications that are approved in Canada, what it does is it kind of works to boost one of the chemicals that we think is important for memory. And so the chemical that it boosts is actually one that's blocked a bit by amitriptyline. So that's why in this case, we would probably say, let's try to come off the amitriptyline, try another sleep aid for this person to help them with sleep that doesn't block that chemical, and then start a medication like donepezil or Aricept. And that boosts the brain chemicals that are important for memory to stay around a little bit longer. So you remember I showed that synapse, that area between the two brain cells. What happens is the chemical's released, then it's broken down. This stops the breakdown and it keeps that chemical around a little bit longer. But what it doesn't do is change what's happening in the brain. It doesn't stop those amyloid and tau proteins from building up and killing off brain cells. So it doesn't extend the life of anybody with this disease, with Alzheimer's dementia. But in the shorter term, it maybe slows things down a little bit so they don't change as much over the next 6 months or a year. Yes?
How long can the Brazil work?
So if we look at the research information, the research studies, all we have is information from most of the studies were 6 months. Some of them were about a year. In my practice and the information that I have, I usually, when I start someone on donepezil, I'll continue them on it and until, either they're at a later stage of dementia or they have a side effect or a problem because of it. And the reason for that is because the studies, they can only go so long before they have to show whether they're effective or not. We then kind of follow people over time, and there's some evidence from observational studies. Again, when you kind of just see in the real world what happens when we follow people over time, that these medications are maybe still helping a bit. And then there's evidence to say when we take them off, it's hard to predict, but a certain percentage of people do seem to have a more rapid change or decline. Or at a more advanced stage of dementia, sometimes they're not really doing much for the memory and thinking anymore, but maybe they're helping with some of the behaviors that are associated with dementia. And so coming off the medications, behaviors can get a bit worse or come out a bit more. So generally, I keep the person on a medication. From the research, what I have from the scientific evidence, I know that they're effective for 6 months, a year, maybe 18 months. I can't say are they still helping over 5 years definitively, but most of the evidence points to it's reasonable to continue these medications. We only go up, so with donepezil, you can only increase the dose from that you start at 5 milligrams and you go to 10. That's the highest. So the studies looked at doses higher than that, and there was no benefit. It didn't help the person anymore, but there was more side effects. So like any medication, we sort of unfortunately hit a main level or a high level where we're getting the best benefit and the least amount of side effects, but going any higher doesn't help. So that's the unfortunate thing. And there's no evidence to say, because there's other medications in that group, there's no evidence, unfortunately, to say, well, you've been on donepezil for 2 years, maybe galantamine will help better than donepezil. Let's switch from one to the other. So we don't do that, because if you're on the one, you would just stay on that. There's nothing to say that a different type in the same group is going to work any better. And then after this, we want to follow up and obviously see how the person responds to the medication. Around 15 to 20% of people have to stop medications like donepezil because of side effects. So we need to check on that, and also just make sure the right sort of supports are in place, and see how things are changing over time. So you can see this person got a little bit of mild nausea, but it went away after a couple days. So we'd say continue it. If it was really bad, we might have to stop. And then we want to look at changes over time, and make sure that people are set up with the right supports and places like this, they're in contact with the Dementia Society and know what's out there for resources. And then planning for the future and then things like that. Okay, so understanding the pathology. As I talked about before, dementia is complex. Dementia is not one thing. It's an umbrella term for the process where people change over time. That's not part of normal aging, where there's problems with memory and thinking that are impacting your day-to-day life. It is not one thing. So Alzheimer's is one type, but that is only one type of dementia. And there's ideas that many things coming together are probably causing dementia in many people. And because it's very complex, it's hard to know everything that's happening. So we know that amyloid and tau are bad for the brain. Sometimes people can have some of that and not have too much of a sign, or too bad in terms of their signs of dementia. But what are the multiple things that have to come together for people to have these problems? The issue with that too is when it's a very complex disease like this, and it's not just sort of one thing as the cause, right? Like we know, if you have a COVID infection, well, that's the cause, right? And we try to treat the COVID, and if we cure that and it goes away, things get better. When we look at dementia, and dementia might be due to Alzheimer's changes in the brain, vascular changes in the brain, inflammation, changes in blood flow, changes in glucose and sensitivity to insulin and things like that. All of these things are presumed to maybe impact brain health. And so the other difficult part, as I mentioned, is right now, most of these are clinical diagnoses. So I don't know 100% for sure. Our accuracy is, in specialty clinics is somewhere closer to 75 or 80%, but that's not 100%. So, we can't take one drug that might work for Alzheimer's and then say that's going to cure all dementia, because people who have vascular dementia or frontotemporal dementia or Parkinson's dementia have a very different process happening in their brain. So there's not going to be one cure. Again, we look at other complex diseases like cancer, right? Even if you look at something like lung cancer, there's different genetic mutations, different types of lung cancer. So we are working hard to identify some of the more common things that we could do, but it's a complex disease overall. So the understanding, though, and I think a change that's happened over the last decade or more, is understanding this complexity, which is good, because we're not just kind of focused on saying, okay, there's amyloid. Amyloid's bad if it's in this form. That's what causes Alzheimer's. Let's treat that, and we're going to make everybody better. We're realizing, no, we're going to have to look and say, okay, we need to figure out ways to keep people healthier through their lifestyle, through their lifetime, treat inflammation, treat changes in blood glucose metabolism, and treat blood vessel and vascular disease. So as we talked about, and I brought up this too, is we're not always 100% sure of the diagnosis when it's a clinical diagnosis. So we might, bring 100 people into a trial and we say, we think, all these people have Alzheimer's disease, whereas realistically, unfortunately, you're going to get, 10, 15, 20, 25 people who don't have Alzheimer's disease, but had very similar symptoms. The other part that makes research complex is, again, it's very nice if you take something that's very simple and easy. Someone has high blood pressure, that's their only problem. Someone has COVID, that's their only problem. Let's treat that. But then we get people, especially as they get older, people have multiple medical conditions. And so that can complicate, when we recruit people into trials, because if you do have other things that we know might affect the brain and brain health and memory and thinking, sometimes that muddies the water a little bit when we're trying to figure out what's the thing that's getting worse over time. Again, the easiest kind of study would be you have high blood pressure. We're going to try a medication. Either it brings your blood pressure down or it doesn't work. But we're not worried about, okay, well, is this person also experiencing depression that might increase their blood pressure? And then we have to know, were some people affected by that depression? Were some people affected by, other changes by their heart disease or things like that? The other part that's challenging is we've made, pretty amazing advances in treating certain diseases in animals, but they don't always translate to human studies. And that's because we are very different from mice and other models. Now, having said that, the advances that have been made because of this basic science has been incredible. A lot of the drugs that we're using right now to treat many conditions, cancer, blood pressure, different things like that, have come from, animal testing. But the problem is often we have to test hundreds or thousands of different medications before we get one that moves to clinical trials and then shows benefit in humans. And the other thing too is mice don't really get Alzheimer's. So we have to figure out a way to, how do we change the mouse to be a model of this disease? So they often will do things like, induce genetic changes and put genes into animals to cause abnormal amyloid buildup and things like that. And then we sort of, cause the disease as the model and then try to treat it. So that's a part of the difficulty as well. And so this doesn't this doesn't replicate exactly what we're seeing in people, but it gives us a starting point, at least to know what might be helpful and what might work. So another thing that is difficult is, okay, yeah, so it's a little bit farther too. By the time we see symptoms in someone, probably a lot of changes have already happened in the brain. And that's a big problem with dementia and our neurodegenerative diseases. So, I often give an example of Parkinson's disease. It's the same in Alzheimer's. By the time someone presents with memory loss, they've probably had Alzheimer's changes in their brain for 5, 10, 15, even more years. And only when it reaches a certain point do we actually have symptoms. So that's very hard to now look and say, okay, we're going to diagnose you 10 years after you've had the disease. There's all this change and damage, and brain cell connections have been lost, brain cells have been lost. Now we got to not just stop the disease, but how do we reverse that, right? And so that's why I think it's been difficult to treat these types of diseases. When we look at Parkinson's disease, and Parkinson's is a good example because it has changes that are pretty specific to, at least early in the disease, a single part of the brain, very deep in the brain, that it's a single type of cell that is important for initiating and controlling movements. And it's not until you lose about 80% of the cells in that area where people start to have symptoms of Parkinson's disease. So we're way behind trying to, salvage those cells and keep that part of the brain healthy by the time someone even comes in with their first sign or symptom of this. So, and then the other thing too is by that time, maybe other things have started to be impacted, right? So maybe the Alzheimer's proteins that are building up are causing more inflammation, or they're affecting blood vessel health. And we already talked about this. So there's not going to be a drug to cure dementia. I wish I could say, we'll do that. We'll find one thing, but we're treating multiple different diseases and a condition that has multiple causes. And realistically, the most common cause of dementia, especially as people get older, is a mixed dementia. So very few people have pure Alzheimer's disease, and we can say that's the only thing. Especially, even more so when we look at people over the age of 80 or so, they almost all have multiple changes in the brain. So they're going to have a bit of vascular disease, a bit of blood vessel vascular disease, a bit of Alzheimer's changes. Maybe there's actually a bigger overlap than I think we realize between people with Alzheimer's changes and Parkinson's changes. So all of these things kind of build up in time. But knowing that, we at least have better strategies to kind of think about, well, it's not going to be one drug. So we need to think of, we're treating this, but we're also going to address these other factors. And research and study, inflammation, that's important. Research and study, if, again, numbers are not exact, it depends on the study, but if, maybe 10 to 20% of people with Alzheimer's also have the Parkinson, changes in the brain, well, we're going to need to figure out a way to treat both of those. So again, the idea as well is I showed you the neurons and brain cells, and those are the main, they're the important cells in the brain that are sending signals, allowing me to move around and talk to you and remember things. And those are the powerhouse of the thinking process in the brain. But there's a lot of support cells there too. So we have the neuron, that's the one that makes the signal and sends the signal to other neurons and allows us to do all these amazing things that we can do. But there's also that wiring of the brain, right? So if there's no electrical wiring, this signal goes very slow. We would not be able to, process things as quickly. So these, what are called oligodendrocytes, are important to cause this insulation of the neurons. Astrocytes, they are sort of support cells. They clear out some of the toxins and things that build up in the neurons, and they also provide other things. And then there's other microglia, which are like immune cells, and they clear out infections and other waste products and things like that. So when something is affecting the neuron and all the amyloid plaques and tangles, the amyloid plaques and the tau tangles might primarily affect the neuron, but then they start to potentially affect other things here. And then we also know other things like inflammation can be good if you're ill or you want to fight an infection. But if it goes a little too far overboard, things like microglia that were good and they're taking out, the waste products, they're taking out viruses, bacteria, well, maybe they start to attack neurons as well, right? So, and then things like inflammation can be higher in people with plaques and tangles. So you start with one process and it kind of, snowballs to affect other things. And so, although the symptoms may just be from problems with the neuron, the rest of the brain might be impacted and not as healthy. So this kind of leads to what I was talking about a little bit there. One thing might have multiple different consequences. So, the buildup of amyloid may be one of the first things that starts, but then it actually starts to make some of the tau go abnormal. It starts to cause, the blood vessels to be a bit less healthy. It starts to impact. So when we sleep, we have waste products cleared out of the brain, and they go through special channels or receptors or pores. And those are sometimes impacted by amyloid protein and reduced. So we don't have that good clearance of toxins. So you can see, it gets more and more complex the more we learn about that. Yes.
And previously you mentioned sleep apnea.
Yes.
Is there a higher correlation with respect to the memory impairments? For example, if I'm not sleeping at all,
yeah,
I'm highly likely, I'm guessing, to be less mindful, only because I haven't had a chance to gear down and recharge and all the rest of that stuff. So in your research, has that often found to be highly correlated?
Yeah, so there definitely is a link with obstructive sleep apnea if it's not treated properly, and cognitive difficulties. So is it directly causing Alzheimer's? Probably not. But if you don't sleep well, as you say, the next day you're fatigued, you're not as attentive, your reaction time's not as good. So definitely it can be one of those, additional factors that causes problems with memory and thinking. So, we want to optimize people's health and treat things as much as possible. And so, yes, with untreated sleep apnea, definitely that fatigue the next day, the lack of restorative sleep, people do have more problems with memory and thinking. Yeah.
The other reverse that you mentioned, REM disorder.
Yeah, rapid eye movement.
So,
Yeah,
for example, if you're a kid and you're one of those ones that sleepwalks, right? Or the one that's flailing around all over the place, is there also a higher correlation if you're predisposed to that?
So thankfully, sleepwalking is separate generally from REM sleep disorder. Yeah, so sleepwalking and when kids usually get like flailing or things, that's actually more considered something in sleep medicine they call night terrors. And that is not the same thing as rapid eye movement behavior sleep disorder. That usually comes on later in life. It can involve movements around, sometimes sleepwalking, but not generally. Sleepwalking is thought to be a different process. So it's a different type of sleep disorder, and it doesn't have the same link. So, if you sleptwalked as a kid, don't worry that you're going to get Parkinson's later in life. Thankfully, there's not that same link. And yeah, and the problems that kids have where they, like flail around or wake up and be quite distressed is usually, again, night terrors, which is a different type of sleep disorder, and usually they grow out of. Okay. Well, you're welcome. Okay, so we talked about here, and I talked a little bit about this, very complex pathway, right? So you start with amyloid building up. Oxidative stress is just a big word for things that cause inflammation, leading to brain loss, and then the cells don't transmit as well, and that's the cognitive changes. And then when you can't think and remember things as well, you start to have changes in your day-to-day functioning. And some of these changes are just happening as we get older, but it's hard to target one thing overall. Again, the loop two of chicken and egg problem here, we can't definitively say that the amyloid is that's not the starting point, right? It is a bit of the cyclical thing, right? So inflammation might predispose people to have more abnormal amyloid buildup, which worsens inflammation, which goes back and forth. Or if someone starts with a bit of abnormal amyloid, maybe that worsens inflammation and it goes back. So again, a very complex process. It's not like we can easily say that, when Alzheimer's starts, this is exactly the first thing that happens, and that's then leading to all these other changes. So that's where, again, as I mentioned, in research and in the research world, there is more of a realization of this. And when you look at Alzheimer's conferences now, you have people from infectious disease, from immunology, people studying inflammation, people studying diabetes, people studying vascular and blood vessel health. So there's a lot more groups looking at this and working together to try to say, this is a complex problem. We need complex solutions, but also multiple different treatments to help with this. We did get into this a little bit more, but this is a good representation of, if this is where, let's say, in Parkinson's disease or Alzheimer's, the amyloid or alpha-synuclein builds up, you could have years and years and years and years, and then only do they start to show signs when we get to that kind of orange and red level. So, we've had lots of changes before here. And if we really wanted to say, if we found that, when the start of amyloid changing is the part we want to stop, and that is really part of the cascade that sets everything else off. Well, you'd want to treat it here when we have no idea that's already started. So that has been a big problem in these trials where, if we get to here and you've lost, or you've had 10 years of changes and damage to the brain, maybe you can't reverse it completely. So maybe these drugs that clear out amyloid are working really well, but there's too much change that's already happened, and they can't reverse what's happened. They can maybe stop and slow things down, or maybe there's too many other of those side pathways going off, right? We fix amyloid, but now there's too much tau or too much inflammation. So that's a big issue, and that's why these tests, like the PET scans, blood tests, we want to start to move this needle back, or this arrow back here, right? So if you are going to start to have problems in your day-to-day life around here, well, what happens if we can say, oh, well, maybe you're a little bit more forgetful up here, and then we can test and say, oh, you're a bit more forgetful, and you have some amyloid changes, and you have some changes that suggest Alzheimer's. Let's start to intervene there. That might actually be where we can, do a better job. And some of these new drugs, or the drugs that are looking at clearing out the abnormal proteins, might start to work better. So you don't, you stop that process that's losing brain cells over here. Yep.
Is there also age factor? Let's say you start showing MCI in your early 60s.
Yep.
compared to somebody who's starting to show NCI in the late 70s? Is there like a curve of decline that is faster in the younger?
Generally, yes, but more so because if you've made it to 90 and you're just starting to show memory symptoms, you probably don't have a lot of Alzheimer's changes. So this disease probably impacts people earlier on. It's not that it can't happen, and there's definitely 90-year-olds who have Alzheimer's changes, but they actually have done studies of people, and they have some studies that actually only enroll people after you hit 85 or 90. So they're looking to say, what's different about those people, but also, some of them are to say, why do people age to 95 and they're still healthy and don't show signs of dementia? What they find, though, is the people who have dementia over the age of 85 or 95 are most commonly have less Alzheimer's changes and more of multiple other things. In general, those things progress more slowly. So someone with vascular changes, it can happen very sudden if you have a stroke, but in general, if it's just slowly progressive vascular changes, it's going to progress more slowly than Alzheimer's changes. So more likely, if someone's presenting with memory problems in their 50s, 60s, early 70s, there's where you're going to see Alzheimer's changes. But when people are older, there's usually multiple changes that have started to build up, and you've just finally hit a point where there's enough little vascular changes. I don't want to complicate things more than we've talked about already, but we're actually finding some new proteins that I haven't even mentioned yet that are more likely to change as you get older. And they don't have as dramatic an impact as amyloid and tau, but by the time you're 95, maybe they do cause changes in the memory areas of the brain, right? So those are the things, but thankfully, again, they progress a bit more slowly. So yeah, in general, if the person is older, it's more likely a mixed dementia, and it can progress a bit more slowly. But it is different, right? So someone who's 85 who has a lot of Alzheimer's changes and Parkinson's changes in the brain, they might, progress quickly too. So yes.
Previous slide with the three circles, you've got regular aging.
Yeah.
You've got mild cognitive impairment, and then you've got extreme stuff.
Yep.
What does the profile of mild cognitive impairment look like? Because I see significant, but what's that significant? 10%, 20%, 50%, you're in that group.
Yeah. So the research definition is very strict. So the research definition is for mild cognitive impairment, you have on a neuropsychological assessment, so a very long, complex set of testing that takes like an hour and a half, you have a decline by 1.5 standard deviations from the normal population. So that's the very, complex sort of specific thing. In general, though, we would, neuropsychologists are not, at every clinic. It's a very specialized training. We thankfully have some at our clinic to help, but so the profile in mild cognitive impairment would generally be milder than dementia, but there's not a specific way to say. So you'd say if someone has significant difficulties in at least one cognitive domain, then they could have mild cognitive impairment. And again, if I was doing a research study and I had to do the official research criteria, you'd have to do a full neuropsychological test and have the person be that much off on their tests. In the real world, in a clinic, how I would diagnose mild cognitive impairment is using my own cognitive tests, so some of those screening tests like that mini mental state exam or the MOCA, and see that people are scoring lower than expected. But then when you do a full, very detailed history and get information from them and their partner or their family, nothing's changed in their day-to-day life. So there's not really actually, so if anything, mild cognitive impairment is even more variable than dementia, right? So it can be milder changes. Someone could have that stage just problems in memory, just problems in language, or you could have a little bit of milder problems in multiple things. So yeah, there's not a real it's a very mixed picture with mild cognitive impairment. And sometimes people do quite well, like you look and their memory tests are terrible, and they can't take in any new information on the memory test, but somehow in their day-to-day life they're still managing to do the things they've done out of sort of rote memorization for so long. So people can have sometimes fairly striking difficulties in testing and still be functioning not too bad day to day, but that is a risk factor that they're going to get worse.
Observations from a family member. If it's like, oh, that's odd, that person really had great orientation in terms of knowing how to get around, and all of a sudden, one day, they don't know where they are. But it's just for that one moment.
That I would look for other causes. So if, these types of diseases that, again, mild cognitive impairment could be caused by a stroke or something like that, but these types of diseases are slow and progressive. So someone with Alzheimer's, the noticeable changes happen over, months, not days, and generally not really weeks even, right? But sort of over months. So if if something changed fairly dramatically, I would be looking for signs of a medical condition, like an infection causing a confusional state, an acute stroke. Those would be those. So, and actually, we use that when we're trying to make a diagnosis of dementia and think that it's a neurodegenerative disease. When I get a history, I find out how long have these symptoms been there for? How quickly have they been changing? Have there been any sudden changes? Because if someone said, yeah, and I've had cases of this where people have had, very select stroke in a certain part of the brain, and the family was like, September 18th, 2023, there was a big change, and that is not Alzheimer's disease. Yeah. But it's definitely something it helps us because we do look for those profiles to be able to kind of say, I think it's this more so than this. Yeah. And then, so research studies, the difficult part of research is when we look at different types of studies that are publicized in the media and different types of studies in general. When we look at these two terms here, sort of correlation and causation. So a lot of the studies that we see, you get the studies like, oh, well, this new drug is going to cure Alzheimer's. And then you find out, well, it did this in a small sample of rats, and it worked really well, but we haven't even tried it in humans. The other thing that sometimes things get publicized a little bit more is things like an association found in a study. So I'm going to talk a little bit about different types of studies, but one of the types of studies that we look at that is the best to sort of determine this thing is definitely causing that is where you take two groups of people and you give them an intervention. So, the easiest way to think about it is two groups of people with high blood pressure, and you give them a medication. Some people get a medication that the active medication, and other people get a placebo or a fake medication that looks like it. And then hopefully, if you do the study as best possible and you make it right, that's the only difference between these two groups. And by the end of the study, you see, did that medication help or not? And there we can say, okay, that's, if all of these groups were pretty equal in terms of the types of people they were, the types of medical conditions they have, and the only difference was really that blood pressure, and that blood pressure pill improved blood pressure, that's probably a good idea of causation. So, this blood pressure pill is causing that reduction. It's not because, one group started to run and took better care of their health. That's the complicated parts of research. What other types of studies are, though, are what we call observational studies. So you just take a bunch of people, you follow them over time, maybe you have them fill out surveys every few months or check in on them every year, and then you see what happens and changes over time. And then you start to look and say, okay, maybe I'm interested in dementia, and maybe I'm going to follow a whole bunch of people for a period of time. And then I'm going to ask them about their health habits. What do you eat? How often do you exercise? What other medical conditions that you have? And then you start to look together at the people who ended up developing dementia. What were the things that were more common in that group versus the others? That gives us a correlation. So that could just be because that's, in any group of people, when we do a research study, sometimes things look like they're associated, but it's just, because of that group that we picked. Sometimes it is a good marker of a true cause, like, smoking and lung cancer. Obviously we can't do a controlled trial, especially once we started to learn more about it, where you say, okay, you guys are going to get real cigarettes, you guys are going to get fake cigarettes because we think smoking causes cancer, and then we're going to see if the people with cigarettes got more cancer. But there was enough evidence that could be pulled from observational trials or trials looking backwards to say, okay, people with lung cancer, very significantly were more likely to have smoked. So initially, in the first few studies, oh, this is an association. These are correlated, meaning they're linked together. One seems to happen more often with the other. but it doesn't necessarily mean that that's the cause of that. And so, a good example of this is, I'm sure people have seen studies for, let's say, like dark chocolate improving having a lower risk of heart disease or improving memory later on, right? So one study comes out in the news, dark chocolate is great, take this and it improves your heart health. And then another study, oh, it doesn't do anything. Or another study, oh, actually, people who ate more chocolate had worse heart outcomes. So that's where you can see, if you do enough studies, you may find different associations. And only when you can clearly say, okay, I've done 100 studies and every study showed me that, maybe you could start to look and say that correlation is probably stronger and maybe that's a cause. The important part of these types of studies is obviously they're easier to do. And they can give some information to say, like, again, with smoking and lung cancer, once that, association is found, you can start to link back and you can look at studies that are going to prove that this is more of a cause, right? You can look at it in animal models, because for animal models, you could do a study where you expose some to smoke and others to not and see if that causes cancer or changes in cells. So that's how we made those sort of associations. But the difficult part is when you just follow people, or the other type of study, which again, useful for maybe finding factors that might cause some of these problems, but not the best study because people don't have the greatest memory for things. If you ask someone to look back, if I, took a bunch of people with high blood pressure and I said, okay, now tell me your habits. I'm going to give you a survey and you're going to tell me, how many times did you exercise in your 40s? And, so those are called retrospective studies. And again, they have a good place in research. They can tell us a lot, but sometimes the conclusions that we can come from that are not as strong because people may not, remember as well as they think they do, or again, depending on the groups that you've picked, if they're not equal, then there could be many other things that were there, right? So maybe the person who exercised more, maybe their heart health was better because they had a more general healthy lifestyle. And again, I'm not going to say exercise isn't important, it is, but let's say exercise wasn't important, but they are also the people that didn't eat fast food, every couple days, right? Just that, in general, if you had a more sort of healthy diet and lifestyle, then, maybe the thing that we asked about, exercise, if we didn't ask about diet, maybe it was actually the diet driving these problems. So that's the difficulty with those types of studies. Whereas when we do that's a good example of that, where we do a controlled study, we can sometimes say, okay, this is the only thing we're trying to change. And so here's a good example of correlation. So this is really strongly correlated. Whatever these two things are, every year when one went up, the other went up pretty closely. And this is where, if you just take enough information and sort of try to find associations, you can find things like, the number of, if we look at US spending on science, that correlates positively with the number of people who have committed suicide by hanging. So probably not something that's actually happening together, but from a statistical analysis, this is a great correlation. So a strong correlation doesn't always mean there's a true link between these two things. But as I mentioned, this idea of a randomized control trial is thought to be kind of the gold standard, the best thing that we can do to really tell us if this outcome of interest is the actual thing that's happening. So a lot of these are done with drug trials. And as I mentioned, if you're testing a new drug, you want to have two fairly equal groups test the drug, so we can say the only difference between the two groups is, again, this drug. Because if you don't balance them equally, let's say we were testing a drug to treat or prevent lung cancer, and we had this drug that actually worked really well, but we had groups that weren't balanced well. And so the group getting the drug had a whole bunch of people that were smokers, and the group getting the placebo, the non-drug, had no smokers. Well, we might actually see the group with the drug that's helping and preventing lung cancer have more cases of cancer because they're not well balanced. So what we try to do in a randomized control trial, and what it means by randomized, is that when people enter the trial, the researchers don't know what group you're going to be in. So you take 100 people and you use some statistical software to say, out of those 100 people, 50 go into group A, 50 go into group B, but it's not just like 1, 2, 1, 2. And then the reason for that is because, in general, if you just sort of take enough people and you randomly put them into two groups, the background conditions that they have should equal out fairly well. So probably you're going to get about the same amount of people with high blood pressure in one group as the other, the same amount of smokers in one group as the other, and things like that. And then we're a bit more sure that the change and the cause of the improvement from the drug is only due to the drug itself. And so they're randomized, meaning people are split randomly into the two groups. And then the other things that are done is the person who is in the trial shouldn't know what the treatment arm they're in. So they don't know if they're getting the drug or the placebo. And then same thing with the people testing them, they shouldn't know because, again, not that obviously they're, not that researchers want to bias their results, but unconsciously, everybody has unconscious biases. And if I knew that someone was on something and I really wanted this to work, maybe their performance on a test looks a little better to me, not because I'm trying to, make a lot of money off this new pharma medication or things like that, but just because, unconsciously, you're going to grade things a little bit differently. So the best trials, the people going into the trial, they don't know what they're getting, and the people testing them have no idea what they're getting. And it's only at the end do we say what's called unblinding. So both groups are blind to what's happening, and then we look to say, okay, did we have groups that were equal, and did that change that we were looking for, like blood pressure being reduced, really happen, or it's not being influenced by anything that the researchers are doing. And that's how we can get a better idea of, if this is the only change, this is causing that. Okay, and so I talked about this already, so I won't go into this too much. I already said observational studies, you look about the effect of an exposure. So, what was your diet like when you were younger? What was your exercise pattern like, and things like that. And then you watch over time and see, who gets more incidence of heart disease or dementia, things like that, and then try to find the associations to say, well, that group that got heart disease, they exercised less, they ate more fatty foods, and they smoked more and things like that. And then you start to do other trials to say, okay, well, now I'm going to try to prove that those are the real causes of it. Again, so I skipped ahead within some of these. So you ask people, again, you can do an observational study where you follow people from the start and you ask how much they consumed over the years, or you can do it what they call retrospectively. So you can take someone after they have the disease and ask to think back about what they did over time. And it's a bit less reliable. Okay. Oh, no, that's okay. No problem. If amyloid and tau are bad, how can we measure? So I already mentioned, I can't see into people's brains. I am fairly good at making a clinical diagnosis, I think, but not perfect. And there's no way for me to absolutely know. And, unfortunately, the neurodegenerative diseases and different diseases, they don't follow the medical school textbook. It'd be very nice to say, this is the profile of someone with Alzheimer's disease, but and this has been often mentioned at the Dementia Society, when you've seen one person with dementia, you've met one person with dementia, and people present very differently, even though they have the exact same disease affecting them or changes in the brain. So we're trying to get a bit better during life of trying to figure out how do we measure amyloid and tau. So this is actually a PET scan. A PET scan measures the amyloid binding tracer, and I talked about this a little bit earlier. So scientists have developed an amyloid tracer. So this is a little thing that can be injected into the blood vessels. It flows through the whole body, and then it tags on to abnormal forms of amyloid. And then we do the special scan that lights up when you have the abnormal amyloid, but not normal amyloid. So a control generally means someone who's healthy, who we don't think has the disease. And you can see here, they don't have high levels. Red is obviously higher. People with very mild cognitive impairment, maybe they have it because of a different cause, or maybe they're very, very early in progressing to Alzheimer's disease. And then someone with more advanced mild cognitive impairment, they have more of it. And that's where we could say that would be mild cognitive impairment likely due to Alzheimer's disease. And here would be Alzheimer's disease, and we now have evidence of abnormal amyloid, so we can be a bit more sure in our diagnosis to say this wasn't, unfortunately, just someone who has mostly memory problems. They look like they have Alzheimer's, but it's really just due to vascular disease. So The other part is tau, right? So as I mentioned, for Alzheimer's, we think it's due to abnormal amyloid and abnormal tau. So we need to be able to measure both of them. They're different proteins, so we need different tracers. Same idea though, it's just a different type of tracer, and it tags on to the abnormal form of tau. And again, same sort of thing. We do the scan. If things look pretty low and change, that's healthy. And in an Alzheimer's patient, it's much, much higher. Other ways, so I think, yeah, I think it was Dr. Knufel was last week. So, so he likes electricity, you can see, with his cars and, and research tests. So this is a study looking at an EEG. So again, less invasive than doing a spinal tap and less expensive than doing a PET scan. You know, not great though, you get your hair a little messy and there's a little gel that goes on there, but yeah, much better than potentially, you know, having to go through something like a lumbar puncture. So you know, studies have been looking at, there are normal sort of brain waves and electrical signals that we can see in EEG. And this is, you know, after doing a certain task, you might have a little spike in certain brain activity. And in some people who are having problems with a mild cognitive impairment, that spike might be delayed. So, you know, you can see that their processing of certain information is slower. So that's something that's being looked at as a way to help diagnose as well. And again, it would be a little bit more easy to do than the PET scan or a lumbar puncture. Other tests, so we're trying to standardize, you know, right now people have to come into the memory clinic, you have to have someone trained in how to give these clinical tests. Are there ways to, you know, maybe have people do it without someone there? So they could be, you know, time related to their visit with the doctor or nurse could be more related to talking about the disease and not doing as much testing. So computerized tests are being looked at. So cognogram is one of them. I would say, unfortunately, there's a ton of these, and we need to sort of come together to find, you know, one or two that are really effective that could be used. But cognogram is one at looking at different, you know, can you remember the card that was turned up and different things like that. So it's got a sort of a group of different tests that you do. Depending on your performance, it has it gives you a likelihood of this may be due to Alzheimer's or dementia, or this is mild cognitive impairment versus normal performance. But I mean, as you know, we have more opportunities to use technology. Again, these types of tests could be really helpful, beneficial, maybe even start to screen people at the home, right? Like you could do something on the computer to say, hey, I got to get checked out, or things seem, you know, oh man, I forgot the laundry detergent downstairs 3 times last month. You know, should I have this checked out? Well, these tests might help a little bit, you know, more. But we have to be pretty confident of that, right? I don't want to send something out and either give people false hope that, you know, their test is normal, so they don't need to worry about things when something might be happening, or get people more worried when they're, you know, they're normal, and that was just a, you know, a normal memory lapse that wasn't a problem, but now they're worried that, you know, this has told them they might be developing dementia. So advances in treatment. So looking at how we do clinical trials, and as I mentioned, clinical trials are very difficult. They take many, many, many years. You have animal testing that's done. And so before even starting a clinical trial, usually there's tests done on animal models, and there's going to be hundreds and hundreds of compounds tested, or thousands, before you get to one that moves to a clinical trial. And they have very rigorous sort of protocols and you know, to make sure that we're really truly finding the right bit of information. You know, is that drug really helpful at clearing out amyloid in the animal model that we use, so we can try it in people. Once we have enough information to say we think this will be effective for a certain disease, things move to a phase 1 clinical trial. And this actually is people without the disease, because what we're learning here is, how does the drug work in humans, right? How does it get processed? Is it the kidneys that are filtering it out? Is it the liver that's filtering it out? How much of the medication is helpful? You know, what is the dose that we do? Like when we talked about the dose for donepezil, you know, they tried higher doses, people got more sick, and it didn't seem to be helping or the level of the chemical in their blood. So we do blood tests, we do tests, you know, of where is it being processed by, how long does it stay in your body for, you know, do you need to take it once a day, twice a day, 5 times a day? And so this is just a smaller number of people, and you know, you get a lot of information on what the drug, what's happening in the body. Then you start to say, okay, this seems safe. Nobody got really injured or sick from it. And we can measure it and it's getting high enough in the blood level, or, depending on what we want to do, like for drugs that need to get to the brain, we have to be sure that they're crossing through the blood-brain barrier, which is a tight seal. So, we have to be sure of all those things before we start testing it in patients. And then you take a small number of patients. And again, now you're going to see in people with this disease, do they react to it the same way that healthy volunteers did? Do they have more side effects, or are there more problems? Is it, and then are we starting to see a signal of benefit for what we're looking for? So did that blood pressure drug in people with we know that have high blood pressure start to reduce their blood pressure? Or did that memory drug start to slow people's changes in memory? Once we have a signal that it's safe, or that it may be working, and we know that it's safe, or at least the side effects that might happen are comparable to other drugs in that group, or at least tolerable, then we move on to a phase 3 trial, and that's now we need thousands of people, and usually over months or years to do these tests to really see, is this helpful or not. And the other thing too is, so if it's a totally new drug, then you can just test it in a group of people with that disease. But if it's a drug for something that is already has a treatment for it, again, I'm going back to blood pressure because it's an easy one to explain. But if you have blood pressure drugs that work pretty well, and you say, well, I want to invent a new blood pressure drug, well, Health Canada, the FDA in the States are going to say, well, you got to prove to us that that's better, or at least as good as these drugs, and somehow, safer, things like that. Why are we going to put a new drug on the market that is, works the same, or has more side effects, or things like that? So you either have to test it against nothing if there's no treatment in that group, or you have to test it against someone on that therapy to say it's better or works just as well and now has less side effects. That would be a benefit to people too. And there we're usually doing trials that are run by drug companies. They are done at multiple sites. So a protocol is made by a lead researcher, generally at the drug company, with maybe in consultation with other scientists at other universities. But then this trial is going to be done at dozens of centers across North America, Canada, the States, Europe, and test these drugs. And again, this process takes millions, billions of dollars, many years, and thousands of people. Again, once this all goes well, this is a very controlled setting in these trials. People are generally excluded when they have certain medical conditions, or they have too many different medical conditions. So then we say, okay, well, now it seems to work. We're going to move it into the public. It's approved by Health Canada. But once things are done, we do the final analysis to say that it works. And then once it's approved, you still need to follow it over time, right? Because a lot of these trials, like you mentioned, I asked about with, how do I know donepezil is working 5 years from now, or 5 years after it started? I don't have great evidence, but because of observational trials, I can say it's probably better to keep it on than stop it. Those trials only told me what happens over 6 months to a year. The other thing too, though, is side effects don't always happen within that first period of time. So we need to follow people for longer with the drugs, because maybe new things will happen over time that were not found in the trial because it was too short, or we didn't have enough people, or maybe people with certain conditions that were excluded in the trial were now using this drug and it interacts somehow with that other type of disease. So it's not over once it's even approved and used in medical practice. We need to keep watching and seeing what happens with that. So this is the reason, though, that unfortunately, this is such a long pathway, and to go from all of this amazing work that's being done in laboratories and universities, and these, again, the research that we hear about in the media saying Alzheimer's was cured, and then in a mouse, is these preclinical stages, right? So we get great results sometimes, but then a lot of drugs just fail in phase 1. Oh, doesn't really work well in humans. It doesn't get into the right parts of the body. That has too many side effects, so we lose that. And then some move to phase 2. Well, the person with the disease, it worked well. Some don't, and then we move to the larger ones. And Alzheimer's disease research has unfortunately been a big area where a lot of these phase 3 trials have been the ones that have failed. So we've gotten these promising drugs all the way to large trials, and then when you look at the group that got the drug and the group that didn't get the drug, there was no real difference. What we're doing, yeah, so that's where we're saying there's little progress to date, although there are 2 new medications that have shown promise. And yeah, so we do have those in here. They are both now approved in the States. They're not the silver bullet. They're not the be all end all treatment, unfortunately. They are a big step forward because they're treating the disease. We're treating right now, as I mentioned, donepezil works by just, it's kind of like a boost, right? It's like turbocharging your engine a little bit, but it's not fixing. If your engine's already broken, maybe you can go a bit faster for a while, but it's not fixing the problem that's breaking down in your engine. That's what they're trying to do. So they're trying to remove the abnormal amyloid plaques and the tau tangles. The little progress to date is probably in part because by the time, as I mentioned, people have symptoms, maybe if you remove a whole bunch of this amyloid and tau, you're too late to make a big difference. But we're starting to see that maybe we can make a difference, not a stopping of these diseases, but a slowing down. And the difference between these is if these show promise past 18 months again, so that's that idea of we know what they do in 18 months, but what happens to these going forward, right? Do they come back together? And so the drug is helpful for a short period of time. The goal and the benefit would be, if this keeps going like that, that's great, because if we start this really early, that person who has MCI, maybe they still develop dementia, but maybe they develop dementia a year later, 2 years later, 5 years later, right? So that's where, these could be promising. But lecanemab, and there's another one called donanemab. So these are antibodies that bind to amyloid. They do a great job. So this here is looking at that PET scan that I told you. So the one that had a lot of red on it. So these people went from looking very, very red, lots of amyloid, and it actually took away a lot of it. And some people went back to almost looking like this, right? So, or more, let's say more like that, a little bit, right? So it cleared it to a point where it was almost undetectable or less detectable. But unfortunately, even though this is a huge change, the clinical change, so this was a test that looked at a memory test and a day-to-day functioning, it was significantly different, but only by a few points, right? So you can see, the test of it, out of 80 points or whatever, there's a difference of about 0.1 or 0.6 on this test, right? So the difficult part when we look at these things called the clinical dementia rating scale, sum of boxes, so that's 18 point scale, is 0.4 difference noticeable, meaningful to people? That's where the difficult part is. Statistically, yes, it's different. And from a research perspective, that's significant and positive. That's a positive test. But nobody cares if their test is a little bit better, if they still progress to dementia, if they can't pay their bills, if they can't do things. So that's the difficult part with these drugs. Very promising because we're starting to see this benefit. It does significantly change this slope, and it does seem to slow down the changes that are happening. And again, we might find that maybe there's a percentage of people that like this change is this big and it's a huge benefit and noticeable. And then there's some people that don't really respond, and there's other people who have side effects. And that's the other downside to these medications. So donepezil, as I mentioned, 15 to 20% of people have side effects and can't tolerate it, and we have to stop it. But those side effects, you stop the drug and they go away, right? So the difficult part with these drugs is they have a bit more significant side effects. So if we look at the people, and we talk about any event in terms of people on lecanemab versus placebo, and why so many people on the placebo have events is because anything that happens in a clinical trial, you get a cough, a cold, you stub your toe, you have to tell the people in the trial, and that's considered an adverse event. Now, we look at that and say, okay, you stubbed your toe, that wasn't the drug, but maybe that rise in liver enzymes was the drug, right? So, but you can see, when there's this much difference, so there were more adverse events or things that are happening when people were on the drug. Serious things happen to people even when they're, some people might have passed away, some people might have developed cancer. That wasn't because of a drug, right? So you can see that happens with a placebo, but it was a bit higher in people who are taking the medication. The big thing with these medications is that they can sometimes cause swelling in the brain, and they cause a slightly higher rate of little microbleeds or mini bleeds in the brain. Thankfully, most people had no symptoms of this, right? So the only reason we knew that there was an area swelling in the brain is because we had regular MRIs in the study, and they would have never known. Would it have gotten worse? Maybe in some people. Would it have eventually had symptoms? Maybe. Around a few percent of people had some impact of it, and only around 1 or 2% of people had serious side effects, right? Like a significant neurological change that didn't completely get better. So then the difficult part, though, is if we're having a reasonable amount of people with these changes, even if they're not causing symptoms, are they causing any harm? Hopefully not, but maybe, because the swelling, at least in the brain, seemed to go away after we stopped the drug. And so when we look at these ARIA, so that's amyloid-related imaging abnormalities. So amyloid's the drug we're thinking of, related to that. Imaging, we see it on brain imaging. And so ARIA-E is that edema or swelling. ARIA-H is hemorrhages or bleeding. So you can see here, if we look at the drug versus no drug, obviously, it's 12% versus 1% of people. So people with the drug are more likely, because of the drug, to get swelling in the brain. If you had certain genes that predispose you to a higher risk of Alzheimer's, so this ApoE4 is one of those genes, people who had 2 copies of it were much, much more likely to have potentially swelling. And so you can see here, so you've gone from, 10, 12% to 30%. So a third of people that had 2 copies of this had swelling in the brain because of the drug. And then same thing with the microhemorrhages. So those do happen to people over time. And actually, with Alzheimer's disease, Alzheimer's can affect the health of the blood vessels, and you can get little microhemorrhages. So again, 9% of people, 8% of people had these microhemorrhages just from having Alzheimer's disease, but then double that had them with the drug. So there's more of these things. So that's the balance, and that's why they're still being sort of looked at in terms of, is this much change worth potentially these side effects? And as I would say, if this much change keeps going like this, probably, especially if we start it early enough and we're monitoring people closely, and we can stop and we can say that maybe a lot of these edema, that's reversible, right? It happens, we reduce the dose, we stop it for a while, we start it again, and it doesn't come back. And it wasn't going to cause, any permanent deficits, but this drug is helping. The hemorrhages, a little more worried that those are causing, accumulating injury or problems, but they're still very small. So again, it's an expensive drug. It has a statistically significant benefit, but maybe only a small clinical benefit, and there's some more severe side effects. So the fact that Health Canada hasn't rushed to just approve these, I don't think it's a bad thing. And we're getting more real world evidence of how things work, right? So past 18 months, what's happening to this, right? Because if, as I said, this just comes back, then these aren't going to be as beneficial. But we can show in the real world that 3 years from now, some of the people who are on the drug have not converted to MCI or dementia. That's a benefit. And then some of the stuff that I do a little bit more is using home technologies. So things like sensors to look at what's happening in the home. The idea behind some of these is we try to keep it as unobtrusive as possible. We're not putting cameras in people's houses. We're doing sensors that can't tell us exactly what's happening, but give us an idea of home activity. So, how do people move around their homes, and how much time do they spend in different rooms, or what's the, how much time do they spend out of the home, and things like that. How do they sleep? So the bed mat. How do they take their medications? We have smart pill boxes that look at that. And
Hello?
what we're finding with this, and what this is trying to be used at, is getting a bit better idea what's actually happening in the home, what matters to you, and what's your day-to-day functioning like, not just, out of a 100-point test, did you drop by 2 or 3 points?
Hello?
So, looking at things like, are you having problems taking your medications? Are you, using electronics less, or sleeping not as well, or less active? And so some of the work by other groups and groups here has shown that we might be able to use this in a few different ways. First off, maybe we can detect people early. So as I talked about, moving those arrows back up to that green level when there's early symptoms, what we're finding is before people start to show deficits, sometimes when you're collecting a lot of data and continuously, we can see that subtle variations in the pattern of activity, things that you were doing on a regular basis start to become more variable. Maybe that's a marker of mild cognitive impairment. Also, you could potentially follow people over time and say, when I give a medication, I'm relying on the person to call me back or the next time I see them to see how well it worked. If I was doing something to say you're sleeping poorly, maybe if I have a bed mat or some other sleep tracker, I can show that, okay, you were sleeping 4 hours a night. Now I gave you this medication that's supposed to help with sleep, and you're now sleeping 7 hours a night. So you can monitor things over time. And then the other thing is to and see how people also respond to certain interventions and treatments. And then you could also monitor over time. Is that person progressing at more of a rate that suggests a degenerative disease like Alzheimer's, or maybe is it only subtle changes and maybe it's more vascular change? So that's some of the things that we're looking at with home monitoring tech. I'm also interested in looking at caregivers, and can we detect information about time and effort spent on caregiving tasks, start to develop ways to determine when people are experiencing higher levels of burden, and maybe you could intervene by saying, if the sensors are telling us that there's a lot less activity, a lot less sleep, or problems that we might need more help with. All right. Right now we have, as a group here in Ottawa, we do have multiple different trials going on for memory research. Some of it, is looking at those areas that you'd looked at, home monitoring technologies, looking at some of the flyers out there, looking at the microbiome, so gut health, how does that relate to Alzheimer's, looking at new ways to diagnose Alzheimer's using eye movement tests or even just how we blink. Those are some things that are going on right now. And so we do have, right now there's no current drug trials, but we're looking to sort of bring some of those back. So those are testing some of those drugs like lecanemab. We were involved in trials like that. Actually, we were involved in the donanemab trial, not lecanemab, but we've done trials like that. Intervention trials, so testing technologies in the home or certain programs, and an intervention that's not a drug. So, maybe a caregiver support program, does that help reduce caregiver stress? That I made that one up. We're not actually doing that right now, but things like that. Technology trials. So we do, as I mentioned, home monitoring, and could we use smart home and sensor technology to monitor people over time, detect dementia early, detect changes in memory and thinking, or when people go on and off different medications. And then a longitudinal disease progression trial. Briere also has the Canadian Longitudinal Study on Aging. So that's one of those really good observational trials where you're taking, hundreds of people or thousands of people following them for years, and then starting to identify what are risk factors for things like dementia by, checking on people every year or so. So those are some of the things we have. These are the ways to contact our clinical trials unit if you have any interest. These trials aren't only for people with a diagnosis. Some of these trials, as I mentioned, you need people who are healthy and don't have the disease to serve as a marker to compare against. Some of the longitudinal trials, only enroll people that are healthy and follow their health over time, and then check on and see what happens if someone gets one of the diseases that that trial is interested in. Obviously also we have trials involving people with mild cognitive impairment and dementia. All right. So yeah, to learn more about that, with any trial, there's pretty strict inclusion and exclusion criteria, right? So we want to be pretty sure we're testing people with the disease, but we also want to look and say, okay, if this drug we think is only good for people at very early stages of the disease, if your cognitive testing shows you're at a moderate or severe stage of dementia, you might not be able to participate or go through this trial. Or if we're looking at a trial that we're trying to focus on one population, we're looking at people with Alzheimer's disease, you might not take people with signs of Parkinsonism. So that's where, calling and asking about what's happening is the best way to know, because each trial has different inclusion criteria, what we need to see that the person has, and exclusion, if you have that, you can't go in the trial. Different studies are, involve different amounts of visits and commitment in terms of the trials. Some of those longitudinal trials, it's sort of I'll see every year, come by and that's it. We'll do some tests at the time, and then you live your life through the year, and then we're going to check in again in a year. Some of the technology trials, involve testing people at the start to get a baseline, installing some technology, and following them people over weeks, months, or longer. And then maybe, you do a visit with the researcher only every few weeks, every few months, or every 6 months or something like that. The drug trials, usually those are more visits. People are coming in maybe every few weeks. There's cognitive tests, there's the treatment that are being given to them. Some of the new drugs, the other difficult part is they're infusions, so they're not something you can just take at home. You have to go to the hospital somewhere to get these infusions. So that obviously involves visits. And so they're usually, involving more commitment of time and visits and things like that. But with all of these, without people volunteering to do these trials, we won't make these advances and have new medications that might help people. So we obviously are very appreciative of any volunteers for any of the research trials that we're doing, or just, scientific research in general. So, having an idea once you call, if you're interested in trials, of what the trial may entail can help you to kind of decide, what you might be interested in doing. And all of these are voluntary, and it's very important for people to know that we appreciate people helping. But if something changes in terms of your desire to do that, then these are all voluntary trials. So this is one of mine, but so will be a little self-promotion for all of the trials that are our research institute, and so not only things that are involving sort of the studies that I'm involved with, but some of the other researchers. You can see the flyers out there, but this one is looking at using a calendar-based training system that was developed as a part of a program at the Mayo Clinic to try to help people with mild cognitive impairment remain more independent. So this is just a survey for people with mild cognitive impairment to go through and do to say, like, is this something you'd be interested in? How would you want to do this intervention, and things like that. This is looking at a new way to detect and diagnose dementia. So this is looking for people with mild cognitive impairment, mild Alzheimer's, or normal controls, or sort of healthy volunteers, to look to say if we use sort of EEG recording and blink changes in how people blink and the way the pupil moves, could we have an easier way to diagnose Alzheimer's early? And so those are the two of the main ones right here. This study, I don't know if we're enrolling any new patients anymore, but this is another one looking at using eye movements measured from an eye tracker and also just a webcam. Again, trying to figure out, are there ways that don't involve just coming to the clinic, using technologies or ways. And then the other thing too is this is looking at speech and eye movements, and maybe, before you score lower than expected on a cognitive assessment or a memory test in the clinic, maybe there's subtle changes to your speech or even subtle changes to your eye movements that we can pick up earlier. All right, any questions?
Right. Hello.
Okay, I've gone almost to my time.
All right. All right. Just one thing. So if you have any question, I'll pass the microphone over.
Okay.
Just, if you don't mind.
Yep.
People can hear mine.
So you're saying that you no longer have drug tests right now in Ottawa, right?
As of right now, the Briere Research Institute doesn't have any drug trials enrolling for Alzheimer's
So
disease.
donanemab is done?
Donanemab is yeah, that trial is finished, other than people that are still being followed, because some of these trials you do the 18 months and then they have an extension of the trial where they again try to see what happens to people afterwards. And sometimes they also, people who are in the placebo trial may get the drug after if it was found to be helpful. So we're not enrolling any new people in that trial right now, but we are looking at opportunities to be involved in new drug trials, in concert with other pharmaceutical companies that are testing new medications.
Was there another similar drug that with similar to donanemab that was being tested?
Yeah, so the
Lecanemab?
lecanemab, lecanemab came out first. It was the first phase 3 trial to have a positive outcome, and then donanemab later the next year was the next one to come out with a positive finding in the trial. They work similarly in that they clear amyloid, and so both of those trials have finished. But because again, we're still trying to figure out, is this like how clinically meaningful is it? At least, they've been approved in the States, but the FDA has said they need to see another trial. So, they are retesting and doing something similar for both lecanemab, and not yet, it hasn't started, but the drug companies are required to do this to keep their authorization and approval. And so there's going to be other trials that will be enrolling to say, we want to make sure if we do this a second time that the results are just as good or better, right? Yeah.
Any other question for Dr. Thomas? Let's see if we have a question from the audience online. Okay. Yeah, so I can see, so you can actually post your questions on the Q&A box. I can see there's a question here. So the first one is there a difference between someone who forget objects like detergent example you gave from someone who forgets events or information they were given a few minutes, a few hours before?
Yeah, so those are good examples because those would be things I'd be more worried about. So if everybody's forgotten, especially if you have tons of things going on, you're heading out to 6 different events and you forget to lock the door or something like that, or again, there's lots of things on your mind and you have something in your head that you want to go get somewhere else in the house and you forget. Oh, and often that might come back when you walk down. No, but yeah, so if there's a consistent pattern of people forgetting details of conversations or memorable events, right? So I couldn't tell you what I did last Tuesday at 10 o'clock, but if I was out with my kids on the weekend at a sporting event, a week later, I should be able to say, oh yeah, like my son was in a gymnastic competition, he placed 3rd, right? Those are things you should remember. So yes, that's a great example. Those would be things I'd be more worried about. If there's regular forgetting of details of conversations, recent events that are memorable, or repeating of questions like they asked about. So, where are we going tomorrow? Oh, we're going to the doctor's appointment. And then the next morning, oh, are we doing anything today? Where are we going? And oh yeah, I already told you we're going to. Those are concerning changes.
Okay, so there's a question here. It's a bit more personal, but it says, our mother is 85 years old. She's undiagnosed, has shown a steady decline, and most recently has become bedridden. Is there a reasonable path for us to get a diagnosis?
Yeah, so not knowing more about the situation, the referrals to places like a memory clinic and referrals to any specialist would come from a family physician. So I don't know what sort of, assessment or things have been looked at there. Someone who's older who may have more problems than just memory, because it sounds like maybe there's some physical issues there. A geriatric clinic or a geriatrician might be a more appropriate assessment. So we have geriatric day hospitals or geriatric clinics that, our clinic specializes a little bit more in, it's not that we only look at memory, but that's the main focus. So most of the people that would come to our clinic have, a memory as their primary problem. People who have maybe a few more concerns, like memory is one of them, but maybe, changes in mobility or many other health conditions, things like that, then a geriatric assessment might be beneficial.
Okay, another question. Briefly, what is the process for getting a drug like lecanemab approved, I guess, in Canada? And how long does this process usually take?
Yes, okay. So after a drug has gone through all of those testing, phase 1, phase 2, phase 3, to have an approved drug, generally both the Federal Drug the Federal Drug Administration and the Health Canada will look for studies that have 2 positive phase 3 trials. So that's the first sort of bar to cross. You have to, again, show that a second time. And that's when I mentioned lecanemab and donanemab are needing to show a second trial. They were approved a little bit faster because they did a really good job at clearing amyloid, and they showed some benefit clinically too. So you generally need 2 phase 3 trials that showed positive results to have an approval by Health Canada. That, the drug company goes through these years of testing and thousands of patients. They get the positive results. They then bring that to Health Canada and submit a request for an assessment and an approval of a drug in Canada. The process for that, can take months or even more than a year. So it's very different, and it depends again, also on, I guess, how strong the evidence is, other factors that they'll have to look at. But generally, Health Canada will have its own experts, but then it'll have a scientific review committee who will go back and take a look at the trial and advise Health Canada. We really think what the trial is showing is really good, and this would be a good drug to approve. But it can take months or years. So after the drug seems to be showing benefit in trials, and they've published the paper and they've got the evidence to show that, it can take months or years before Health Canada approves.
Okay, so it's 7:58, so I'm going to take only one more questions to wrap up. Is there any interaction between donepezil and mirtazapine?
Not generally, no. So that's two medications that I do sometimes use in patients with memory problems. The mirtazapine is an antidepressant for other people to know. It can be helpful for anxiety symptoms, symptoms of low mood in some people. It also helps a little bit with sleep. In general, there's not a major drug interaction. One thing to look at, though, is certain side effects that are common in certain medications, like stomach upset and things like that, might happen in both of the medications. Things like dizziness. So both of those might combine to cause it, but there's not a major interaction between those two drugs that would be overly dangerous.
Okay. Well, thank you so much, Dr. Thomas, for this great lecture. I know research is a topic that a lot of people are interested to learn about. So don't worry, I know this is a lot, but you will have the recording. Everybody, thank you to everybody who made it today here in person. I know sometimes it's hard to get here to the office late night. And for all the who actually stay online, we have about 20 people online. Thank you, everyone. Just a reminder, next week, no session. Then we'll continue on December 11th, Wednesday, December 11th, and December the 18th. So we still have 2 more sessions to go. And we're going to have a new handout. So stay tuned for that handout. I highly encourage you to follow all this until the very end, because overall it's a great learning experience for you guys. With that, I have to say thank you, everyone. Have a great night. Thank you, Dr. Thomas, again, and I hope everybody stay well.